When there is complex trauma, the assessment is even more complex. And hence, how do we assess them in a way that we are able to identify the core issues and eventually address them? In this video, I'm going to take you through a case study on how we assess and the process of assessment's effectiveness in addressing the problem. I'm Gunjan Trivedi, and let's start with a case study of an individual in 40s. Notice that I've changed certain details of the individual to protect the privacy, but this individual came to us about a year ago. We worked with him for about 8 months and fantastic results. Let me start with what did we discover in the assessments. Notice that a good problem, when defined effectively, is half the job done. So I'm going to spend more time in understanding the situations that the person experienced, the history during the childhood, and so on. We have certain algorithms that at this point I'm not able to share that helps us identify the risk for complex PTSD. One of them is very strong exposure to trauma during childhood, specifically of emotional nature. And this is something I can share because it's part of a publication that focused on childhood trauma occurrence or prevalence in PTSD assessed subjects. So in this case, this individual has been exposed to, and as you can see now on the screen, a very strong repeated emotional and physical abuse, emotional neglect, witness to intimate partner violence several times, mental health issues or depression in the family, isolation by the peers. So bullying can be of two types. One of them is peer aggression, and peer isolation is the second type. And finally, parents fought regularly in the household. So several of these experiences happened before the individual turned 18. So this is history in very short summary. In addition, the person came with very poor scores of depression, very high level of anxiety, very poor sleep, and poor well-being. And then I go into certain social aspects. The person felt that he had moderate social support, his resilience levels were low, psychological resilience, and felt lonely as an adult. So these are adult situations. And between the current situation when we assessed and the childhood trauma, there are certain experiences that I would like to summarize. There was a history of self-harm and a history of suicidal thoughts, which is part of what we call suicide behavior that includes thoughts, a plan, and attempt history. Here it was only thoughts, no plans. I go further. There was dependency on porn as an adult, and eating disorders history with specific challenges with respect to irritable bowel syndrome or stomach issues. The person also had trouble in relationships, and both the PTSD 3 buckets as well as the functional impairment or DSO 3 buckets had 1 or yes, and the score for PTSD was high and DSO was high. Therefore, we identified that the individual has complex post-traumatic stress disorder. So with this history, we started working on it. Now please notice or note that if I summarize overall, very high exposure to childhood trauma, history of self-harm and suicide behavior, relationship issues, eating disorders, and issues with respect to attachment. So there was a very strong attachment with one of the parents while growing up, and as an adult, that became a porn dependency issue. Surprising enough, we also assessed the parenting style and discovered that this person followed less than ideal parenting style. So desired style is more authoritative with a combination that is healthy for warmth or support as well as control. In this individual's case, the warmth as a parent is missing, and there is strong control, which is less desired authoritarian style, my way or highway style. And the last, we also do a lot of work on financial well-being, and that requires certain components of financial resilience. Despite having 3 of the 4 components of financial resilience, the well-being, financial well-being was poor primarily because of perceived understanding or knowledge. For perspective, the person has been very successful as an individual in the family as well as out there in the business. However, the perceptual financial well-being was very poor. Now, why does this become a complex post-traumatic stress disorder? There are certain conditions that I will share. Very high exposure to trauma, very high levels of depression, relationship with self. For example, measured by major depressive disorder. Depression or major depression inventory level of about 26. So this is second condition, and re-experience sense of threat and avoidance where with respect to certain traumatic situations present, and a lot of functional impairment components, especially the self-esteem, the mood or depressive tendencies, and relationship issues were present. Together, all of this told us, based on the ITQ or International Trauma Questionnaire assessment, that the person had all the components present for self-assessment of complex post-traumatic stress disorder. This is just a background. Usually, when you identify this, there are events attached in the recent past as well as the similar emotions happening, re-experienced from the events that happened during early childhood years. So we use a concept called index trauma, something that we'll talk as a concept in a separate meeting or separate conversation. Index trauma based assessment was done, and that confirmed CPTSD, and then we used both a combination of Innerchild integration and reconsolidation of traumatic memories, which uses a very powerful neuroscience-based intervention that works on implicit memories and more specifically emotions attached to those memories. When we started working with this, there was a lot of resistance. So this is one common theme across individuals who experience CPTSD, compared to what you call BPD or borderline personality disorder, where the relationships are more volatile. The CPT individuals are usually more withdrawn, and therefore they don't connect that easily, or there is resistance in continuing. Remember, functional impairment is another common theme that is present. So all of this were present. Thankfully, this person was not one of those 30% individuals who stopped the therapeutic interventions. He persisted, and after about 8 sessions, we started to see results. Like I tell as a metaphor, if you take walnut, you need to break the shell. And that's a similar challenge with complex PTSD individuals. The breaking of the shell is usually part of the re-experienced sense of threat and avoidance, and you can see that in the graphic. And that is connected to childhood trauma measured events. So none of this is abstract. All of them is measured with certain levels of SUDS outcomes. When we are able to break the shell, it's a first step. It does not conclude, but it starts to make things happen. When we started to address situations, the depression levels start to reduce. It does not change, however, the relationship with self, the mood disorder, and how I connect with people, the functional impairment, which becomes more prevalent in CPTSD. So the second phase of work was more on addressing the functional impairment challenges, that persistent feeling that I am not good enough. So a small comment from a family member or a co-worker the person starts to question, did I mess up? And in other words, we also call it toxic shame. The person starts taking responsibilities for everything that he or she has not done. There was a case, digressing a bit, of a mother who did everything, and the mother herself knew that I have done a lot more than what any other mother could do. But when the outcome came, the mother felt responsible for not doing enough. And when I asked the mother, imagine 50 other mothers sampling and assessing you on what you did, and she says 5 stars. But the way the mother felt was horrible. This is a classic case of relationship with self and self-critical or critical with self issues. So coming back to this individual, the tougher part is not just breaking the shell, but digesting what is inside. So eating is enough, but the digestion and therefore changing the behavior and the relationship itself is an aspect of transformation that is more challenging. Now, here a common pitfall, and I'm talking more for psychotherapists, psychologists, is that most of us tend to work through logical reasoning on relationship itself. But it is so convoluted because of the shell or because of the re-experienced sense of threat and avoidance components. So unless this is addressed, this is not available on the table to work. And therefore, you need to have a very sensitive way to working this. And there's a layer that prevents the person who may be disassociated or prevents himself or herself from going to those events which are painful, which is very normal, common sense human approach. So there are techniques to circumvent that shell, allow the person to take us back to those events, sometimes with me not knowing what's happening or what those events were, address them. Now this is addressed, the food is on the table, the core issues are on the table, and that needs to be not addressed but eventually assimilated before the person can change the behavior, how he or she feels about himself and herself. And finally, if I summarize the results, if you look at the end, the well-being was green, anxiety went down by about 1/3, the depression levels went to green or acceptable levels, the sleep got better. This was another challenge in the end where the person kept working and kept busy. Again, that's part of the 4 components of common sense that we talk about with respect to complex PTSD. Fight, flight, which is common in stress. You look at my stress video for that. Then there is freeze. People talk about this as functional impairment. And finally, fawn. Fawn is overly subservient or doing things to please everybody. And that kept the person busy. Overnight working, more than what is required. Again, critical self-judgment also makes the person work harder. So this was a challenge that we had to work through. And when all of that happened, things changed. Also, the dependency on porn incidentally reduced, though we did not work on it. It did not go to zero, but it reduced significantly. And when you look at, for me, the best part was, in the last assessment for loneliness, the person's score says, I am not lonely, which is a breakthrough because now the person feels there is social support. I'm able to connect with people. And last, there was happiness. So before I end, I want to summarize that when you deal with all these issues, which is part of the individual, and they are gone, the person often feels empty. There is no negativity. Negativity is gone. However, the person feels empty. So there is a work needed to bring in motivation, positive things, or start to believe and see things in a positive framework as part of the Release Reframe Toolkit. When all of that happened, the person completed the therapy and asked me, so are we done? I said, my success is when you win and you don't need me. That is our success. But unless you win, I don't win. And that's the approach we have taken. So please share your comments or question about this case. A lot of the data has been shown to you while I was talking. And so if there are any specific questions about what we assess, how we assess the intervention, and the subtle aspects of Release Reframe Toolkit, I will be happy to talk about it. In terms of release and reframe, since I've introduced that term, let me explain that there are 2 steps. Releasing that emotion from the body, memories, cellular memories, muscle memories, and eventually reframing the context, situations, people, relationship, so that I see positives which was otherwise distorted or deleted. So I hope you like the summary, and as always, I would love to have critical comments and questions.